Two people walk into the same hospital on the same day with the same diagnosis. Same condition, same treatment plan, same prescription. One of them recovers faster, follows through on every instruction their doctor gave them, and never comes back through that door. The other one is readmitted within 30 days, and neither of them fully understands why their experiences were so different. But the hospital does, or at least it should, because the difference between those two patients sits on a Medicare penalty notice, a malpractice insurance premium, a physician vacancy posting, and a patient experience score that just costs the health system money it cannot afford to lose. The variable that separated them? Empathy. Whether the providers they interacted with made them feel seen, heard, and sincerely cared for, or just processed. Here on Behind the Business of Healthcare, we look at both sides of this equation. Today, that means the patient who deserves to understand what's happening to them inside the system, and the healthcare leader who is responsible for a system that may be failing both of them. Because the empathy deficit in U.S. healthcare is not just a patient experience problem, it is a margin problem, a liability problem, a workforce problem, and it has a price tag that most health systems are not looking at clearly. Before we get into the numbers, I want to reframe how we're talking about this, because when most hospital administrators hear the word empathy, they think patient satisfaction scores and feel good training seminars. And when most patients hear it, they assume it simply is a matter of whether their doctor was nice to them. Neither framing captures what's actually at stake. Clinical empathy, the measurable, trainable ability of a provider to understand and communicate that understanding to a patient, shows up directly in your financials if you're running a health system, and it shows up directly in your health outcomes if you're a patient. It affects malpractice exposure, readmission penalties, Medicare reimbursement, physician retention, and market reputation. It affects whether a patient takes their medication, follows through on a referral, or ends up back in the emergency department 3 weeks later. It is an operating variable. It belongs in leadership strategy meetings, and it is something patients can and should be equipped to navigate. Here is where we are. The average physician interrupts a patient within 11 seconds of them beginning to speak. That number has barely moved in 40 years of documentation. Physicians now spend 2 hours on administrative tasks for every 1 hour of direct patient care. The electronic health record has functionally become an uninvited third party in the exam room. And the physician burnout, which is directly correlated with the collapse of empathic behavior, now exceeds 50% in the US. The system has structurally engineered empathy out of clinical encounters, and it is paying for that on 4 major fronts simultaneously. Let's start with malpractice, because this is where the empathy to dollars connection is most directly documented and most frequently ignored. A Harvard published study estimated the total annual cost of the U.S. medical liability system at $55.6 billion, including malpractice payouts, legal overhead, and the downstream costs of defensive medicine. That last piece alone, tests and procedures ordered primarily to protect against litigation rather than because they are clinically necessary, accounts for $45.6 billion of that total. Now, here's what is critical for both operators and patients to understand. What actually drives malpractice suits is not clinical incompetence. It is how patients feel about their communication with their provider. Research from Vanderbilt University found that physicians rated by patients as warm, attentive, and fully communicative were dramatically less likely to face litigation, even when medical errors occurred. Physicians rated as dismissive or rushed were sued far more often, even when their care was technically sound. Also, patients who feel they cannot speak openly with their provider are less likely to share the information that accurate diagnosis depends on. MMIC, one of the largest medical malpractice insurers in the country, began mandating empathy training for its policyholders specifically because poor communication drives claims. When your insurer is pricing your communication skills into your premium, that is a market signal that cuts both ways: risk for operators and validation for patients that this problem is real and documented. The second major cost center is readmissions, and this one hits hospitals on two separate lines: the direct cost of care and the CMS penalty structure. Readmissions cost the U.S. healthcare system approximately $26 billion per year. CMS estimates that $17 billion of that is potentially avoidable, meaning patients are returning not because of unavoidable complications, but because something in the discharge process, the care transition, or the follow-up communication broke down. Under the Hospital Readmission Reduction Program, CMS penalizes hospitals with above average readmission rates by reducing their Medicare reimbursement by up to 3%. In 2020, 83% of eligible hospitals received some form of penalty. The average fine was $217,000. Total system-wide penalties exceeded 553 million in a single year. Research consistently shows that patients' adherence to discharge instructions is the single biggest driver of preventable readmissions. And adherence is directly correlated with how well patients understood their instructions and how much they trusted the people delivering them. One study found that up to 62% of patients were more likely to follow their treatment plan when they rated the quality of physician communication highly. 62%. When a patient doesn't understand why they're taking a medication, they stop. When they feel dismissed at discharge, they don't follow up. When they couldn't ask their questions, they go home without the information they need. 3 weeks later, they're back in the ED. For patients, if you have ever left a hospital stay not fully understanding what you were supposed to do next, which medications, which restrictions, when to follow up, and with whom, you weren't alone and you were not at fault. That is a system failure, and it is one of the most avoidable causes of preventable harm in American healthcare. The third major financial lever is HCAHPS or HCAPS, the Hospital Consumer Assessment of Healthcare Providers and Systems, and its connection to the CMS value based purchasing. Here's how it works. CMS withholds 2% of every hospital's Medicare payments and redistributes that pool on performances across quality and experience metrics. HCAP scores, which measure how patients experience their communication with the doctors and nurses, how responsive staff were, how well their care was explained, are a core component of that calculation. In 2019, $1.9 billion in value based payments was on the table for inpatient care alone. But HCAPS is not just a reimbursement mechanism. Those scores are publicly reported on Medicare's Care Compare website. Patients and families use them. Employers who contract with health systems use them. Insurers benchmark against them. Research from the NRC Health found that patients who feel treated as unique individuals, fully seen rather than processed, are 12 times more likely to be a net promoter for that hospital. That is an extraordinary referral multiplier sitting inside what most hospital teams are treating as a compliance survey. Here's the part that matters equally to patients and to leaders. The three HCAPS domains that most strongly predict overall hospital rating are communication with doctors, communication with nurses, and responsiveness of staff. The survey is not asking whether a hospital had good parking or nice furniture. It is asking whether someone talked to you like a human being. For healthcare leaders, a study analyzing 844 hospitals found a direct positive correlation between patient reported experience and future hospital revenue. Your HCAP score is a leading indicator of your financial trajectory, not a trailing sentiment metric. For patients, Care Compare is publicly available at Medicare.gov. Before you choose a hospital for a planned procedure, you can look up how patients rated their communication experience there. This is not a trivial data point. It is one of the most reliable proxies available for the quality of human care you will receive. The fourth cost driver is the most underpriced risk on most hospital balance sheets and the one with the most direct human cost for patients. Physician burnout in the United States now exceeds 50%, and it has a financial cost that most systems are not adequately accounting for. According to Merritt Hawkins, now part of AMN Healthcare, the country's largest physician recruiting firm, the average physician generates $2.4 million in annual revenue for their affiliated hospital. Interventional cardiologists generate $3.48 million, orthopedic surgeons $3.29 million. With a physician leaves, that revenue disappears until the role is filled. The average fill time is 49 days. Merritt Hawkins calculated the daily cost of a physician vacancy at $10,122 in lost revenue, meaning the average vacancy event costs just under $500,000 before you add in the recruiting fees and signing bonuses, which jumped 21% in a single year to an average of $37,000. Here is the mechanism that connects burnout to both workforce costs and patient experience, and why it matters to both audiences watching this. When physicians are prevented from connecting meaningfully with patients, 15-minute appointments, 2 hours of EHR documentation for every hour of care, administrative burden that has crowded out the practice of medicine they trained for, that is a primary driver for burnout. The work stops feeling meaningful. Burnout then produces clinical depersonalization, the psychological detachment from patients that is the specific mechanism through which burnout destroys empathic behavior. So you get a compounding cycle. Structural empathy killers produce burnout. Burnout produces detachment. Detachment degrades patient relationships, and degraded patient relationships worsens the outcomes and financial metrics we just discussed. Mayo Clinic research found that physicians who reported higher meaning in their clinical relationships had significantly lower burnout rates. Connection is protective for the physician and for the patient on the other side of that relationship. For patients, a burned out provider is not a bad person. They are a person whose system has extracted too much from them. Understanding that does not mean accepting poor care. It means knowing that when a provider seems rushed or detached, that is a system failure you're experiencing in real time. You do have the right to name it and advocate for more. Let's talk about what it looks like when a health system treats this as a business strategy rather than a wellness initiative. Cleveland Clinic launched a system wide empathy initiative starting around 2010, mandatory training for every employee in the organization, not just clinicians, custodial staff, food service workers, and parking attendants, everyone. The underlying logic: every touch point a patient or family has with your organization either builds or erodes trust. And trust is the operating foundation of both clinical outcomes and financial performance. Patient satisfaction improved, physician burnout metrics improved. Cleveland Clinic went on to consistently rank among the top hospital systems nationally on both quality and patient experience, which translates directly into their ability to attract patients, recruit physicians, and negotiate favorable payer contracts. The financial argument that may ultimately be most compelling, especially as value based care contracts become a larger share of payer mix, is the adherence multiplier. Non adherence to medication and treatment plans cost the U.S. healthcare system an estimated $300 billion annually in avoidable hospitalizations, emergency visits, and disease progression. Up to 62% of patients are more likely to follow their treatment plan when physician communication quality is rated highly. Diabetic patients of high empathy physicians have significantly better metabolic control, fewer complications, and lower hospitalization rates, documented in peer reviewed research published in Diabetes Care. In a value based care model, keeping patients healthy and out of the hospital is the revenue model. Non adherence is the enemy. Empathy is one of the highest leverage interventions against it that exists, and it does not require a new device, a new drug, or a new billing code. Here is the bottom line that ties all four of these cost drivers together. Healthcare organizations are chasing margin improvements through consolidation, payer contract negotiation, and operational efficiency programs. All of that matters. But there is a variable that simultaneously affects your malpractice line, your readmission penalties, your Medicare reimbursement, your physician retention costs, and your market reputation. And most organizations are not optimizing it because they have mentally filed it under patient experience rather than business strategy. And on the other side, patients are navigating one of the most complex, high stakes systems in their lives, often at the moment that they are most frightened and most vulnerable, without a clear understanding of what they are entitled to or how to advocate for themselves inside it. Both of those failures are costing people. The currency is just different. So let's close with specific actionable guidance for each. If you are a hospital administrator, a CMO, or a CFO, or a practice operator, here is where to start. Number one, measure it at the provider level. You have HCAHPS data and patient satisfaction scores. Most systems have not broken that data down to the individual provider level and connected it to financial outcomes. Which physicians are driving your communication scores up? Who is your biggest liability risk profile? What are the differences in their patient readmission rates? The Jefferson Scale of Empathy is a validated clinical instrument that can be incorporated into provider evaluation. Know your baseline before you invest in moving it. Number two, address the administrative burden first. Empathy training is largely wasted if you're running your physicians at 40 patients a day with 2 hours of EHR documentation per hour of patient contact. The structural conditions that drain empathy must be addressed. Ambient AI documentation tools are showing early promise. Pilots report physicians spending significantly more time in actual patient conversation when documentation is automated. This is a workflow intervention with measurable downstream financial impact, not just perks program. Number three, train empathy as a clinical competency. Empathy is not a personality trait you recruit for and hope survives residency. It is a trainable skill that is evidence based. Programs like Empathetics, founded by Harvard physician Helen Reese, have peer reviewed outcome data. Narrative medicine programs at Columbia University have documented improvements in diagnostic accuracy and empathy scores. Train it, measure it, reinforce it, build it into your competency framework the same way you build in clinical skills. Number four, price retention against recruitment. Every physician loss is a $500,000 revenue event before recruiting and onboarding costs. Build that number into your retention investment calculus. The business case for meaningful work, reduced administrative burden, and empathy supportive culture is directly comparable to the cost of turnover. In most cases, the retention investment is a fraction of the vacancy cost. Make that math visible in your financial discussions. Number 5, align incentives with relationship quality. Your current productivity model almost certainly rewards volume over relationship quality. That misalignment produces exactly the rushed, depersonalized care that drives your malpractice exposure, readmission rates, and HCAP scores. As value based contracts become a larger share of payer mix, the financial incentives are shifting. Get ahead of that shift. Incorporate quality of patient relationship into your performance metrics before the market forces you to. And if you are a patient or a family member helping someone you love navigate the system, this section is specifically for you. The data was just walked through is not a story about hospital finances. It's a story about what the system owes you and often fails to deliver. Here is how to navigate that. Number 1, your discomfort in the exam room is data, not weakness. If you leave an appointment feeling confused, dismissed, or like you couldn't ask a real question, that is a signal about the quality of care you received, not a reflection of your understanding or your worth as a patient. Research is clear. Patients who feel heard have better outcomes. Your sense that something was missing is clinically relevant. Number 2, you can ask the provider to slow down. It is always appropriate to say, I want to make sure I understand this before I leave. Can we take a moment? Or can you explain that in a different way? You are not being demanding. You are exercising your right to informed consent, which is a legal standard, not a courtesy. If your provider makes you feel otherwise, that tells you something important about where you are getting your care. Number 3, bring someone with you. Research consistently shows that patients who bring a trusted person to medical appointments, a spouse, a friend, an adult child, retain more information, ask more questions, and are less likely to leave with unresolved concerns. That second person is not a crutch, they are a documented clinical asset. For any significant appointment, bring someone. Number 4, use the public data that exists for you. CMS Care Compare at Medicare.gov publishes HCAP scores for every hospital in the country, including how patients rated their doctor and nurse communication. If you are choosing a hospital for a planned procedure, look it up. Patient experience scores are one of the most reliable available proxies for the quality of human care you will receive there. Use the data. Number 5, if something feels wrong, say it before you leave. One of the most consistent findings in diagnostic error research is that patients often had information that would have changed their diagnosis and did not share it because they were not asked or because they felt the provider was too busy. If something feels relevant, say it. If your instincts tells you something was missed, name it. You are not being a difficult patient. You are being an informed one, and the research says you might be right. The empathy deficit in American healthcare is not inevitable. It is the product of structural decisions that can be unmade. How we train providers, how we compensate them, how much administrative burden we pile onto their days, and how seriously we take the relationship between a patient and a clinician as a clinical variable in its own right. The health systems that figure this out first will have a meaningful competitive advantage as the industry moves further into value based models. The ones that keep filing empathy under soft skills will keep writing checks for readmission penalties, malpractice settlements, and physician signing bonuses. And the patients who understand what they're entitled to and how to advocate for it will get better care. Not because the system suddenly becomes perfect, but because an informed, empowered patient changes the dynamic in the room. If this breakdown was useful, share it with someone on both sides of this, whether they're running a health system or sitting in a waiting room. Both audiences need this conversation. I've linked all the key studies and data sources in the description: the Merritt Hawkins vacancy data, the CMS readmissions penalty reports, the HCAPS research, and the malpractice cost analysis. Take them into your next leadership meeting or to your next appointment. Subscribe to Behind the Business of Healthcare to learn more about what is happening behind the curtain in your healthcare organization or with your own healthcare. See you next time.